Sorry. Again, we mobilize under four key priority areas. One, to strengthen the capacity of Black communities and its leadership in the United States to engage in policy deliberations in order to improve federal, state, and local policies, programs, and research. Then two, expand the public health and policy and advocacy leadership pipeline in the US South. And then three, enhance the collection and analysis of data to inform solutions for addressing social and economic disparities, driving poor health outcomes for Black communities. And then last, we work to improve the information dissemination and mobilization of health policy and advocacy among Black communities in the South. And so this webinar is the beginning of a series of work that we are working to engage and improve the literacy of Black communities and our leadership to really be able to improve our ability to have real-time impact on policy as it is moving on behalf of Black communities. So we are so excited about the speakers that we have today and advocates who are dynamic in their work to address HIV and end the HIV/AIDS epidemic. And so with that, I would like to introduce our speakers and just to give a little bit of the overview of our conversation today. We are going to have a federal update from Harold Phillips with the United States Department of Health and Human Services, and then a panel discussion with Harold along with two dynamic Black policy voices, Ms. Vanita Ray as well of the Positive Women's Network, and then Matthew Rose of the of Health Gap. So with that, I just want to allow Matthew, Vanita, and Harold an opportunity to introduce themselves and just share a bit about their work. And then Harold, when you introduce yourselves, I'll let you go ahead and go into your piece.
Hi, good afternoon, everybody, and good morning, I think, on the West Coast still. I'm Harold Phillips. I am the Chief Operating Officer for the Ending the HIV Epidemic Initiative in the Office of the Assistant Secretary within the U.S. Department of Health and Human Services. Glad to be here with you all today.
Well, I'll go. Okay. Hi, folks. As Benton said, I'm Vanita Ray. I am now the co-executive director of the Positive Women's Network. It's a recent change we're making. And I live in Houston, Texas, and am a woman living with HIV and have been involved in developing the leadership of folks living with HIV, developing the ending the epidemic plan for the city of Houston in 2016, and doing other work around policy issues, HIV criminalization, and the meaningful involvement of people living with HIV in policy work.
Thank you, Vanita. And Matthew?
Yeah, Matthew Rose. I'm the Director of U.S. Advocacy, or U.S. Policy and Advocacy. Wow, it's been a long week. For Health Gap, we're an international HIV organization that focuses on getting access to essential medicines to people living with HIV and ending the pandemic. And I have a bunch of other hats that are maybe relevant. I don't know. It's always weird.
Thank you, Matthew. And so I want to turn it over to Harold Phillips, who will give us an overview of HHS under the new administration.
Thank you, Benton. And thank you all for inviting me to be with you today. One of the things that, so with the new administration, as you all know, things are off to, things are happening, but we are still waiting for leadership within the U.S. Department of Health and Human Services. The nominee, Secretary Becerra, as well as the Surgeon General and the Assistant Secretary nominee, Dr. Rachel Levine, their hearing before the Senate is tomorrow. So they haven't been confirmed. So right now, we're still in an acting position. But we're very excited, and I'm excited about having Dr. Levine as a new boss, who, if confirmed, will be the first congressionally approved transgender woman in a position And so I'm excited because the toys that she gets in I call them the toys, but they're really the programs and the funding that she gets to have influence over, not only include HIV, but STIs, viral hepatitis, the Office of Minority Health, the Office of Women's Health, the Office of Population Affairs, just to name a few. So she is going to have the ability, and given her experience as medical officer for the state of Pennsylvania, it's going to really and truly, I think, give her the ability to have some great influence into the communities and the issues that we care about. The other thing that we know right now from the White House and from the administration is the focus on systemic racism and equity. It has been coming out loud and clear as a theme during the transition. And a lot of the questions that we got during the transition were around what our programs could do to address the issue of equity. There are not yet a lot of specifics for us about how we would move some of this forward. There are several of us in the Office of the Assistant Secretary, particularly in my office, which is the Office of Infectious Disease Policy, which handles HIV, STIs, and viral hepatitis, where we have some ideas, and we're really waiting for the new leadership to come into place so that we can begin to sort of implement some of those ideas and some different approaches. The other thing that we have been told internally by the administration is that they want us to be bold in our approach. And so I'm excited about that, but I want to see how bold you really are willing to be. Because for those of us who've been doing HIV for a long time, if you give me that, if you tell me be bold, I'm going to come to the table and I'm going to give you some really good ideas, but it would shake some things up and mean that not only us, but agencies and public health departments would have to approach things differently. Some of the other things that I have, and then I'll be quiet, the Ending the HIV Epidemic Initiative. So it was an initiative that was started by the previous administration, and it's the first large chunk of new money that we've gotten to address the HIV epidemic. I think while EHE is not perfect, I think it did a couple of things for us as a movement. One was the additional funding. And this year, for FY21, there's $403 million of new funding. So that didn't, so that will also be helpful. The second thing I think it did is really and truly allowed us to engage different sectors of society around the concept of ending the HIV epidemic. So I think there's been community engagement. We've been working with private industry. We've been working with the healthcare sector, as well as advocates and public health departments, really and truly getting them to understand that this is possible, but certain things need to change in order to achieve that. And we've also been borrowing, I think, from some of our overseas governments under PEPFAR who have moved toward a point of epidemic control and using US taxpayer dollars to do it. But there was both leadership at the government level, community engagement and community buy-in, along with the additional funds. So we still have a ways to go to get some of those pieces in place in order to truly achieve the end of the HIV epidemic. The other thing that I will say that we have is that EHE is flexible enough to allow the creation of different partners to come to the table. We're still in the process of reviewing the the EHE plans that were submitted in December to CDC, and still looking to see, are we still planning to do the same old, or were there different and new partners that were brought to the table? And I think if we're having this discussion about equity and about addressing systemic racism, it calls for us to bring new partners to the table. And we're seeing what happens when you don't with COVID-19. And the requirement of innovation and new ways of thinking and community engagement, all there. And there are instances where we can see where not doing those things have caused delays and are contributing to additional disparities, even as we roll out the vaccine in response to the disparities that we knew were going to happen when COVID-19 hit our communities. So I think really and truly getting us to think about new partnerships in EHE. And while EHE is imperfect, I think as we go down the line and we hear from some of the other speakers, we'll get into what are some of the ways that you can think about as you talk to legislators about changes that could be made within EHE. But EHE, I think as a concept and the ability to end the HIV epidemic is a good thing. The other thing we have in place is the HIV plan, and I can talk more about that later.
Okay, no, thank you so much, Harold. I was just about to ask you a question about the plan, but what I want to do is follow up with our speakers, our additional speakers on providing a response to what was just mentioned. I think that as we talk about and framing a conversation around the administration's commitment to conversations around racism and equality, this was a key reason that we brought Vanita on the line to have this conversation, as it is something that she has been championing for a number of years. And so, Vanita, I want to give you the opportunity to respond first and also raise any questions that you may have about what was shared about where we are right now and how do we get ready to move, how do we move forward as a Black community, and also addressing the epidemic on behalf of the Black community, as they are the ones that lead this epidemic.
Yeah, so thank you, Vinton, and you all for having me here. And I felt like I was a little disconnected in getting ready for here. So please excuse me, I'm still in transition mode of adjusting. But Harold, thank you for your lead. And I'm really, happy to hear and excited about what the potential is of this new administration. And happy to hear the new money. I'm happy to hear the words of rooting out systemic racism and equity and being bold. What some of my challenges are, is that when we developed this HIV, the end plan here in Houston in 2016, we knew that it needed to include a social and racial justice, an intersectional approach, and that is still lacking. And even when we started that conversation, we really didn't understand what that really meant, right? We just knew, and over time, I've come to, understand what it's meaning and begin to champion it. But I think any plan that doesn't specifically call out and which EHE does not yet, issues of racism, and to address first, HIV is a racial justice issue, racism is a public health issue, and that it must inform the strategies and programs that are implemented under EHE. Otherwise, we're doing the same thing without consideration of, those real issues of equity, access, and inclusion. And, to me, COVID, you're right, highlighted some of those gaps that we already knew. Advocates have been talking about the health disparities and things, and it's interesting to be hearing those conversations now. And I would love to see how, we take a step back, because even when EHE, the framework was developed, it's really biomedical focused, and without those kind of quality of life kind of pillars to it, and from a framework of quality of life of people living with HIV. And we know those social determinants of health, those equity issues, if they are not included and a part of it, that we are still going to be in the same place. So I'm happy to hear about being bold. I'm happy to hear about, we've got to shake some things up, because we've got to challenge the way that we've been doing business. We can't have the same power structure in terms of the people who are making decisions, and decisions not being made by the people most impacted in Black communities. I want to highlight Black AIDS Institute We the People report or plan. I'm a part of a group called Black South Rising, who we've issued a political agenda in the South about really holding leaders accountable. How do we fund folks most close to the ground? I'm part of a group called HIV Racial Justice Now, where we've come up with a declaration of liberation, where we have put forth, kind of a framework for a racially just and strategic response to the plan to ending the epidemic. So, you know, we want to be partners in this. And I'm glad you also said, I think we've lacked a little around engagement and what that really looks like. And if folks came to us with a 4-bedroom house, 4 pillars, and it really needed 7, how do we now retrofit that and make it work for the communities? And, you know, I haven't seen a lot of disruptive innovation yet. And I use that word a lot because I love that it was included, because I want to see it. Because, you know, when I first got into this, I was repeating everything that I heard people say. And in the middle of even doing our end plan, it dawned on me that the words I was saying, we could not test, treat, and educate our way out of this. You know, that it's got to be more. And we began to look differently at it. So I think, you know, looking at how we reconstitute PACHA, how we staff ONAP, how we really look at real equity, because the Health Equity Task Force to me isn't really human rights centered or focused around including people with those kind of backgrounds. How we guarantee access to sexual health and sexual and reproductive health, how the National HIV Strategic Plan and the federal implementation plan dovetail with the EHE plan. You know, we made comments to it. It was done pretty rushed without, you know, I really feel like a chance for folks to really get involved. You know, how housing can be seen as treatment, you know what I mean? And if we don't address housing and really think about where housing plays a role in this, you know, the biomedical approach, I think is needed, but it by itself won't get us there either. One of the things the HIV community has called for, and we'd like to ask for, and we've asked, you know, previous administration, is a moratorium on the cluster detection, so we can really evaluate the equity kinds of impact that it has. And it's included as a pillar without a thought to that, because the racial justice piece of it wasn't addressed. So I'm excited to hear, you know, I'm excited about Rachel Levine. I'm excited to hear that we got maybe some bold ideas, but I think those are some of the places that we love to work with you, and we think that really could make this something that the community can work with. But to do the same old thing again, and we're 40 years into this without real boldness, is like, you know, is telling the Black community that the fact that 60% of the women living with HIV are Black doesn't matter. Why aren't we angry about that? The fact that it's disproportionate impact on Black folks doesn't matter, because Black folks were not sought out specifically, and racial justice and equity was not called out. And without those, I think we're still at the same place. And I'm committed to wanting to see a real end to this and working with the new administration to do it.
Thank you, Vanita. All right, I want to move with another reaction to our next speaker, Matthew Rose. In Harold's presentation, he talked a lot about not only the plan to end HIV, but some of the other kind of intersections in the response to HIV and the policy environment, the federal budget, the National HIV/AIDS strategy, the commitment to being bold in addressing systemic racism and inequity. My question to you is, what specific health policy issues are ripe for action in this 117th Congress? And of those, which do you think are most salient for Black leaders and Black communities to be paying attention to right now as HHS and the federal government is ramping up after its transition?
I'll be that annoying person and answer this in 3 parts. First, a bit of framework. One of the things that I'm looking forward to seeing is that we can like put down the woke thesaurus and like actually have some programs and things that happen on the ground. Like, it is now new and in vogue for people to be talking about racial equity, which we've been talking about in this community for decades. It's new. Everyone's like, oh, reproductive justice is part of healthcare. Like, no, we've also been talking about this for decades. So like, just because they've now like come to the table and can say the words, like that doesn't mean much to me. I need to see some actually like programs that show that not only what looks different, but also that it feels different. And I think that some of it is going to be improving on the same old tropes, because some of those same old tropes did not finish out, and we'll see that in Congress. Obviously, the biggest thing that we've seen from a care point, and this is only one part of the care portion that I'm going to say, and I think it's critical, is that the biggest policy change that has improved the lives of people living with HIV in America was the expansion of Medicaid. And so places where we were able to get low-income people health care And then having community, the second part, teach them how to use and access that healthcare, those were massive. And so whatever the administration can do to make that be a thing, to get those states to come along, I'm looking at you, Alabama, Georgia, Mississippi, Tennessee, Florida, North and South Carolina, Kansas, all y'all need to do better. Now, the nice thing is in the current reconciliation bill, and this is one of the great things about the bill, like while everyone's arguing over like the minimum wage, which is very important, obviously, and arguing over these stimulus checks, which are also kind of important, but not as important about what I'm about to say, there are a whole bunch of healthcare pieces in that bill, including a sweetener to try to induce Southern states to expand some of their Medicaid. And if we can get a Southern state to bite on this, and for instance, if you got Texas, Georgia, and Florida to all expand Medicaid to 150% above federal poverty, you could make massive gains in the HIV field. And then if you could get one of the other things that the president is trying to push is that we do more plans engage in what we call silver loading, which means that the silver level plan becomes like the standard plan, but we peg everything to the silver level plan, which really makes you want to push it to go to the gold plan. We could give people access to healthcare that covers not only their HIV, but also all of their other health needs. So radical proposals that are out there, lots of great things that can happen with them. Congress is doing some of this. It's in the bill. There's a tax credit that I'm actually super excited about, a premium tax credit. And normally I hate tax credits. I think it's usually the Republican way of dealing things like, hey, after you've gotten the whole bill, wait a year and we'll give you some money for that expense that you've been carrying on your balance sheet. This tax credit is retroactive for the last 2 years on healthcare expenses. So for premiums that you've paid, so if you've paid any premium expenses over the last 2 years and you've lost, say, your job or your job income has been reduced, you can get that tax credit. And if it passes now, when they want it, so the middle of March, you could use it for this year's tax season, which is just like a windfall of cash back into people's pockets of people who need money. All that said, minimum wage, super important. Why? Because living wages are important. One of the fastest ways to make sure that people have access to healthcare is that they have money to get care. Guess what? The best way, the primary way of getting care in this country is economic employment and what benefits are offered. We know that people being able to pay for those benefits and being able to pay for those are great. The challenge is one of the things we're seeing as more and more support goes into premiums is that deductibles and co-insurance get higher, which means your medical costs are still high because when you show up at the doctor, like, well, I know you got insurance, but you still owe me an arm, a leg, and maybe a pinky toe. And so we've got to figure out something like that. One of the places that is primed for some discussion after this round of COVID relief is going to be on drug pricing reform. And I say that because there are some Republicans who are open to this issue. Chuck Grassley was trying to move a bill last year on lowering drug prices. Now, was it going to be everything I would have wanted? Hell no. But would it have at least started a conversation? Because some of these drug companies have made out like bandits on things like insulin that have been around for 100 years. And we just got to rein some of that in. But we're seeing that people are in a place to say that drug pricing could come down. So, and then the third kind of congressional bucket, and before I get to the administration, is going to be at some point, they will probably do a reconciliation package. It will probably be the third reconciliation package because we cheat and you can do 3 in 1 year, depending on a blue moon happening and the stars aligning. But the second one will probably be on infrastructure. It's a whole other story. But the third one could potentially be on healthcare in general to try to get the public option through. And this is really going to be really key because it would allow a healthcare option that could compete with private insurance, which would mean that private insurance would have to start either upping what they're covering or lowering their prices. And overall, lowering the price and costs is a really great idea. The insurance companies have, if you've looked at their balance sheets for the last year or two, in a pandemic, they've made a whole bunch of money. Now, shouldn't that worry you? More people are getting medical care, and yet the insurance company is getting richer. Shouldn't they be getting less rich because they're paying out claims? Isn't that how insurance works? Oh, wait, not really. So that is kind of where I think Congress has some really unique actions going on. There's probably some other stuff in the margins, closing some loopholes, allowing for some certain administrative rule changes that need to be fixed that the Trump administration did. On the administrative side, you've got a couple things to be worried about and a couple things that we can do good on. So you've got worried about 6 protected classes, so limiting drug formularies. And this is a place where people can now get involved. It's something the HIV community has historically fought, because what it would do to us is it would say you can only have 2 HIV drugs covered by any plan. Now, if you know anything about HIV, people's care is usually tailored to, I don't know, the individual, radical concept. And so forcibly switching people from drugs that are working to drugs that are more affordable for the plan, not such a good idea. And it was one of the fun things that the Trump administration left us with on the way out the door. Sighing. However, on the good side, we can see that the Biden administration, I still love that man sometimes, that the Biden-Harris administration does have the unique opportunity to use CMMI authorities to do some very interesting demonstration projects and approve waivers that actually increase care and do things like allowing for housing first proposals that allow for healthcare things to be paid for by Medicaid, for doing some drug pricing reduction costs that could be done. There's an interesting kind of confluence of things you can do as a demo project that aren't necessarily going to stick around without law, but can at least see what and test what are innovative ideas to allow us to reduce the cost of care and allow care to be more successful. Just like the Trump administration asked everyone and their mother, hey, do you want a work requirement for your Medicare? Come on, you know you do. We'll approve it. Aren't they great? We can also do the opposite and say, hey, here's a really great way to expand coverage at the state level, which is why states are going to be really important in trying to figure out what states pitch to CMS. And we're going to have the nominee for CMS administrator is very progressive. Well, they're not an Elizabeth Warren or a Bernie Sanders progressive, but they are very progressive in terms of health policy, which is not always the most progressive field in some ways. And I have a lot of faith that what they can do and what they're willing to accept and to push on terms of cost containment and cost control and patient-centered care is going to be really important to getting us some better outcomes. So that's kind of a hodgepodge of kind of where we're going, what opportunities you have in Congress and the administration. I'll also say that the president issued a slew of executive orders when he got into office, trying to stabilize the marketplace and system. A lot of those, we're gonna have to see how the rubber hits the road and how those rules get written. The ACA took a big beating over the last 4 years. The Republicans, since it's gotten into place, have never funded the law at the level it's supposed to be at, or any of all the programs the way they're supposed to be. So we've never seen how it could work. So under a Biden administration, we could potentially see the ACA do the things it wants to do and was designed to do for the first time ever. But it's going to take some pushing to do that. And some of that also like assumes this this theory of this race blind approach when they passed that bill. It has closed some of the Black health disparities in terms of coverage, but our outcomes are still pretty poor. And that's something that the ACA does not do a great job on. So that's a place where we have to push. And especially since the Biden team wants to have equity, they're going to have to push on too. So I'll leave it at that for now. I know there's a lot of stuff to hear from.
Thank you, Matthew. Really appreciate the three of you just providing some context as to where we are and how do we move forward in a way that is genuine to the commitment that we all have to end the HIV epidemic, and particularly through this Ending the Epidemic plan by 2030, and making sure that we're on track for that. And so I want to go back to Harold and ask a question. You mentioned that we are in a place of transition, that there's a lot of moving parts. However, we still have a very active plan to end HIV that still needs federal leadership, as many of us on the ground has experienced enormous issues on the local and state level in the implementation of this plan. Many issues addressed were issues that advocates and policy leaders brought up on a number of occasions before it was decided that health departments would indeed be the mechanism to move this work through. So I want to ask you the question, what can we or should we be doing now as the government is being put into place? For many of us, we are waiting for our health departments to receive guidance from the federal government about the final EHE submissions. And a lot of us on the ground definitely aware and sensitive to the number of health departments who have staff who have been moved to COVID response. We understand we still have HIV that we have to deal with, and we have to make sure that we move into year 2 of this plan in a way that makes up for the time we lost in response to COVID. So what can we do right now, Harold?
Oh, that's a great question. And I think thinking about what can we do now, there are a couple of things. The plans that were submitted to CDC in December, CDC is reviewing them. And as I understand it, that review is a completeness review. There may be some things that, or some areas within the plan where there might be an additional need working with an additional need for technical assistance, where the plan was submitted, it's complete, but the jurisdiction might need help with community engagement or implementing some new approach. So HRSA will be making its second year of EAG awards in March, as will the Bureau of Primary Health Care, which scaled up PrEP services in community health centers that were duly funded. There's additional new funding that I think is awarded to health centers. I either want to say June or August, but later this year for sure, for health centers that previously had not been doing HIV work to begin scaling up HIV testing and other HIV-related services. So that funding announcement from the Bureau of Primary Health Care is out there. And then CDC, by August of 2021, will be making its additional HIV prevention, diagnosis awards that also include funding in STI clinics. So all of that, so we're continuing to move forward with FY21. I think what the community can do right now is begin to think about where are the holes in EHE and how to have those conversations with different leaders, both at the federal level, but also at the state level. And one of the things that is emerging from COVID is the implementation of telehealth. And so at the federal level, we're thinking about what worked and what flexibilities were allowed because of the public health emergency. When the public health emergency goes away, are there certain telehealth flexibilities that we want CMS to keep in place? But at the same time, there may be state and local flexibilities that now the federal government has superseded, that those would come back to being in place and might hamper the ability to use telehealth effectively at the state and local level. So the community should also begin thinking about that as well. Because I think it's working for a number of patients, and I'm always in favor of whatever gives people more options. Telehealth is not the magic pill for everybody, but I think it has allowed us to continue having some individuals and services and to reach them. And so I don't want it to go away for those that it's working for. So I think those are a couple of the things. I think Matthew, as he talked about healthcare reform and Medicaid expansion on the local level, some of what I've been reading is it's going to be harder for states to say no because because they're all hurting for money. And so being able to access these new pots of money as a result of sort of the thing that they're calling sweeteners will also be helpful to us in our community. For example, when we think about Texas, just think about if those individuals had health insurance coverage that had a drug benefit, which is sort of a requirement under Ryan White, that matches the ADAP or exceeds the ADAP, then we wouldn't necessarily be in a situation. There are other states that are doing cost containment work right now as a result of this. And most of them are, I think all of them are non-Medicaid expansion states. So that's a really important piece.
Okay, so let me One, let me ask a question that was raised from the audience, and I'm going to follow back up with something that you mentioned. A question came from one of the participants asking, why is HRSA funding so much bigger and uncoordinated from funding sent to health departments? HRSA organizations seem to get more while health department funding is currently being cut.
Would that be HRSA? So I'm not sure I completely.
And hold on, and let me say one thing. And if the person who mentioned that comment wants to unmute themselves and provide clarity, you're more than welcome to do so at this time.
Because HRSA is getting two pots of funding currently. HRSA is getting funding through the HIV/AIDS Bureau, which is the Ryan White program. And then HRSA is also getting funding through the Bureau of Primary Health Care, and that money goes to health departments directly.
Mm-hmm.
And then the CDC funding is going through the public health departments.
Right.
So, and I think also, as we're sort of having this conversation about equity, one of the things I threw out yesterday in a meeting is that we need to look at the way we fund and we look at the funding formulas.
Mm-hmm.
So the money, CDC's money is running through public health departments for the most part, and state health departments, except for the directly funded cities. And yet when we sort of talk about cities that are being progressive and cities that are really forward leaning and thinking, like Houston gets its funding directly.
Right.
Whereas the rest of the EHE jurisdictions in Texas, the money flows through the Texas State Health Department.
Right.
Houston
So
submitted its application directly.
And with that being said, so here's another challenge when we have this conversation. So jumping back to this conversation around the planning and the creation of quality and comprehensive plans that are move us towards the end of HIV as an epidemic in 2030. So a lot of the funding that you mentioned that would become available are, from what I hear, are really spaced to address, some clinical outcomes, Bureau of Primary Health Care, HRSA funding for services, and the like. Where is the commitment or the recommitment or reallocation of funding to make up for poorly executed planning processes that took place on the state and local level as a result of COVID, as well as a result of other issues that may have prevented the full execution of the EHE plan as it was written to be planned. Perfect example. You use Texas and Dallas and Houston for an example. There were $4.5 million of monies from various EHE pots that was supposed to go into our EHE work, and it did. Of that, about $1 million of that was supposed to go to fund community organizations to be able to have a more meaningful involvement. I can speak for Dallas and a number of other jurisdictions that no organization outside of the health department saw EHE money in an earnest way. How are we backtracking and revisiting that error as we move forward, because we know the plans that have been created are not comprehensive, community informed and community led plans to end HIV?
So I think that's another great area for the community to sort of prepare for the discussion with the new leadership about those plans that were poorly executed, that did not involve community the way anybody had hoped. And being able to talk with our new leadership about that, and also figure out what do we want to do. Because I think there's sort of now also this tension between poor plans that we have and the need to execute. Like I said to an agency today, if you take another year to plan, that means more HIV infection in your community. That means more people not in care. So when do we stop planning and begin to move to implementation? And so if the community has another way to help us move toward implementation, then I think that would also be helpful for the new administration to know. And I
Yeah,
think part of what I was saying about the equity piece, I know Vanita wants to say something too, is
I was about to say, go ahead and jump in, Vanita, after you go ahead.
Go ahead.
No, go ahead, Harold.
it is, you know, it's the Houstons, it's the Miamis, it's those counties that we directly fund, that because we give them the money directly, they are in control of their planning process. They are then able to think of different approaches, and then the money is closer to that community. The way we've got it structured now, the money is flowing from many of the state health departments to the jurisdictions, and they're sort of this in between. And if we're talking about equity and we're talking about the need to address sort of the intersectional issues, then what I feel like we need is a city and county health department that's able to bring its housing department to the health department and say, we're going to do a joint funding announcement and fund providers in our community to do this. I can't imagine what that would look like for the state of Texas to say to Dallas, we're going to need you to bring your housing, perhaps housing, transportation, and HIV providers together and go jointly in for an RFP so that we can fund you to address these intersectional issues at the community level.
Harold, let me ask you a question real quick. So with that question, let's say we look at the funding cycles. If an organization, particularly a health department, is funded in September to execute deliverables by February or March or whatever that timeline may be, to execute an RFP at a county level takes much more time than we are factoring into. I say factoring, but I'm using it loosely because these strategies, when we talk about procurement processes and opening the door to disruptive innovation and new funding streams and new funding partners, those relationships on paper and the RFP process is taking longer than what's facilitated. So another example of what's happened in Dallas, our 1906 funding, we lost access to about $70,000 of that money because the proper position wasn't put into place. So it's not the resources, it's the strategies that are not being captured on paper with the clinical outcomes that are being, or the connection between the process and the outcomes are not being put into the local plans. And I'll turn it over to Vanita. I know you've been wanting to share some things.
Yeah, because I just have to push back for a minute. A lot of what I'm hearing is theory of how we hope that this would work, because that is not what's happened on the ground. You know, one of the things, I'm sorry, where we talked about community, you know, figuring out where the holes are in EHE and talking about it. Well, I'm pretty informed, and I can't even tell you what our submission was in December. I can tell you what we did in 2016 and didn't know what I was really doing. We did way more community meetings. I think I may have seen 2 maybe community meetings around from our health department, one with the Ryan White Planning Council, one by the END plan around our EHE plan that was submitted to you all. There was not that transparency. We were not involved. People on the ground don't understand where the holes are. I remember I was on a call, probably Benton, you facilitated this, and with some folks, Antigone and all this, and saying, you guys are describing structures and process of CDC and HRSA. That stuff, from a community standpoint, you don't even know who to go to. And to their credit, a couple months later, they sent out an email and said, Vanita, you are right. We've now produced this document that you can go to the website and look at who the contact to go to, because these different money streams are not very transparent, understood by the community. And it's hard to tell somebody where a hole is when you don't understand what the process was or what the implementation. So I agree with you that when do we start implementing and not just planning? But if we're implementing the same thing because it wasn't community driven and folks weren't really involved, it's still the same thing anyway. When you talk about Texas, you know, you're right. We have the highest uninsured rate in the country. Medicaid expansion is a bad word in my state, you know, period. We're fighting with our state health department right now, who changed its spend down guidelines and eligibility guidelines in December. And that's resulting in 2,700 people potentially being cut, but yet they're also running an Indian epidemic state plan as well as the federal we've got going on. yesterday we got an email where they reversed their decision because, you know, it's cost containment, but there was no transparency. Now they've delayed that till June, and we're trying to have some input. But you can't, those are working at opposite ends. We're fighting, you know, these many fights, and you don't even know where the real fight is, where we're trying to just keep ADAP going versus where is the real structure of how do we influence the EHE planning. Our health department is great, but still, we still haven't hired our EHE coordinator, you know. So there are, you know, I feel like a lot of this is theory about how we hoped it would be, and we're going to be implementing the same old thing without community input. Because you know, I can tell you, I can go to my planning council right now and say, what is happening on the EHE? And they'll look at me, I have done it, no one knows. So I don't think we can, the community can be informed, engaged in an informed way without a better understanding of all of these pieces. When you have CDC driving, that it's prevention focused. And so I'm representing HIV community too. And it's, you know, remember what I told you, we got a framework for a 4-bedroom house when we really needed a 7-bedroom because we need more solutions than biomedical. So I hear you, but I Texas, you know, are we going to expand Medicaid? 2022 election, we got over 30 something bills right now that are our governor and our lieutenant governor said election integrity is one of their top priorities. To me, that means voter suppression. So 2022 still may not give us what we want in terms of trying to get more. So, you know, I think there's a mishmash of policy here. And even those of us that are informed, you know, we can't even explain this to the community in a rational way. So I don't know how community can help identify the best way to implement the holes when they can't understand the process and what it really means, or haven't even seen those plans that were submitted in December. So it feels like we talk a lot about theory, and there's a lot of, you know, TA monitoring, implementation, and all this, and community, it's just hard to understand where is the real way to influence that, or really to drive that, really to get the needs of people living with HIV center in that, and the way to really impact the way that we do this differently. I know that
Thank
was
you, Thank you, Benita. No, but I think that it is definitely on point as we talk about this plan to end HIV, because we definitely understand the funding guidance that is going to be provided. But I think that there is another level of guidance that may not be, you know, attached to an RFP that is needed desperately by health departments and the community of partners that surrounds each of these different communities. Harold, you've definitely been a part of many of these conversations where people outside of the health department don't know their plan, don't know the status of the work, don't know how to get involved. And we are talking about the leaders of these communities, not just an HIV positive person that, you know, just found out their HIV status yesterday and want to get involved. These are, you know, hallmarks, gatekeepers, you know, in these communities and are not aware. So one thing I think that we continue just to really hear, or as a need, is for HHS to provide through HRSA and CDC more guidance to facilitate this conversation around the meaningful involvement of people living with HIV, but also the meaningful involvement of the HIV community in this work. So I want to pause. I was just about to say, I want to pause real quick and see if Matthew had something. Go ahead.
So I think this conversation actually speaks to a larger question that we started this discussion with, and that is, we have systems that are not designed to serve the people who they're pointed to serve. And we continue to try to shoehorn our way into this and then say, well, it's not working. I'm like, no, because it's not designed to work for you. And what we need, I would say, yes, Harold, we could use more guidance, but not just more guidance. We need specific types of guidance that allow for alternate structures and frameworks that community actually is willing to engage with and works for community to get feedback in. One of the interesting things that you draw from the clinical trial world is this idea of adaptive trial design. So we set what our goal is, but we also set some quicker interim steps that allow us to change. And they're not giant like swings of changes, like we're taking away this entire grant, but things that let us look at progress markers quicker and sooner. Now, part of that is going to be a challenge because we don't get data fast enough from the states and jurisdictions, which is why I'm always an advocate for surveillance. But we need to make ways of getting the data faster and then getting the data to the people in the communities quicker in a way that is digestible to them and a way that they can actually give back to the system. And that's the current, and it's not outside, and it have to be outside of the current system because the current system clearly isn't working. And we keep sitting in these meetings about like, hey, let's have more people. But like, you yourselves have said, the Biden administration continues to say, we want disruptive innovation. Well, disruptive means we actually have to disrupt the system. So what can we be doing? And this is what I think people should be advocating for. How does your community best receive information? And what can you agree to as a turnaround and ways of once you've gotten that information to giving feedback back in a meaningful way? And when we figure out those systems, that's what we've got to plug in. But if we keep sitting on the like, it's got to come from Washington, and then it's got to go to the health department, and then the health department's got to find the CBO, and then the CBO's got to put it down to the community, and then it's going to go back up that line. Like that line leaks like a sieve, and we lose people all across it. So how do we actually start pumping new ways and new methods into that space?
Yeah, and thank you for that, Matthew, because, you know, and when I hear a person like Vanita saying, I don't know what's in our plan, it goes back to what you were saying, Matthew, about the way these things are developed. It's a system that isn't working. Me sitting in Washington, I would imagine that, yes, I know she's been at the community meetings where they discussed EAG in 2019 and 2020. And then when that plan was due in December, I would have expected that somebody would have said, okay, Vanita, we heard you. Here's the document. Take a few days, look at it, look at what we've said the priorities are, and the priorities are based on what we've been hearing from you for a year and a half. And then, yes, that document has to go up and get approved, but at least she knows what was in it when it got sent to the state capitol to then be sent to Atlanta. And so what I'm hearing is she didn't see that part of it. She participated in the meetings, don't know what they did with. Two, then the plan was sent to Atlanta in December and she still hasn't seen it. And so that the community doesn't know what CDC has. And so this, where do we go from here, is what really is there. And I appreciate it, because when I'm thinking community engagement, okay, yeah, we got professional writers, but here's a plan, here's what we heard from you all, tell us if we've captured it adequately. That type of community engagement, and perhaps even sign off from the community.
Right. But I
which
think
is required.
Harold, I think one of the things that we discovered is when we use this term community engagement, it means different things by different folks. And so what I thought in HRSA and CDC, it was a suggestion of community engagement. It wasn't even talked about as what it really meant. Who is the community? You know, what, you know, people living with HIV, the HIV, whatever. So this idea, people keep using the term. And so and in their mind, they may be doing it, but is not what we are seeing as community engagement in terms of I participated in a number of meetings. We broke it down. We threw out stuff. We decided what to do. We involved, you know, all these different stakeholders. You know, that's my idea of community engagement, and that sign off, that review that you're talking about. Somebody else might think they did it, but their idea of it was we talked to a few people and stakeholders, or again, I'm gonna go back to the basic framework, or way the framework was decided. The 4 pillars were not, no, the community people, there were what, 5 or 6 men in a room that came up with the 4 pillars when they came up with that, and then brought that to the community and said, now you build it. Well, it was flawed from the beginning. And I think that this flaw continued because, again, from the time I saw the 4 pillars, we were used to use the term as blow up the frame, because we knew that the frame already was flawed from the beginning. And I think the idea of where community engagement just perpetuated, and similar to what Matthew said, the system, the old systems that we've been using for the longest were still the same systems that were used, and they were not the systems that really were designed to really, shift and bring different change, bring, the kind of change that you're talking about and that folks had hoped with ending the epidemic plan.
And
So
so with that, I want to just raise a question that was raised, actually two questions now that was raised. One, and I believe this is for Harold, who are the liaisons or where are the bridges between government agencies and community organizations to the front lines to translate the needs up and the resources down?
So HRSA and CDC both have community advisory groups that they meet with. There's also PACHA, which also engages with the agencies. And then there are, for me, there are various meetings like this where I'm getting input and then having to go back to the agencies to work with them and get certain things addressed. And I use the example of, when the feedback was given to the jurisdictions from CDC, it was the community that came to me and said some community groups in some jurisdictions had not received that feedback when it went out a year ago last March. So these meetings that I have with community are very important to me outside of sort of the PACHA and the CHAC framework. The other thing that, we talked about this piece that doesn't work. And maybe as we think about how EHG can be revised, and part of what I think you want to do with this meeting is try to figure out what is the legislative agenda. And what I've heard Vanita talk about is that the pillars need to be expanded. And then community engagement hasn't worked the way perhaps people, well, I will say for me, I'll use an I statement as the therapist will want me to. It has not worked the way that I would have expected. And I gave you just an example of how I expected community to be at the table and perhaps sign off on the plans before they come to Washington and Atlanta. If we're really and truly talking about being bold, and if we're really and truly talking about equity, then community engagement is not the thing. It's community ownership. It's not that we're inviting somebody to a table that somebody else that is not ours. We're not sort of making a space or pulling up a chair and saying, community, now you're invited to this table to come and plan. That it's the community ownership would mean that the community owns that planning process. The community develops that plan and then says to the federal government, and then says to the public health departments, this is what we want. Community engagement is, I've set the table and now you're invited. And so that's very different. So if this administration wants us to be bold and truly address this, then I throw that out for you all's consideration to stay in my federal lane, to try and educate others about the difference between engagement and ownership around the planning process. Because what we've got, and what I keep hearing is, what we've got currently is not working. And I would have to say that even in my thinking about my expectations, what's happening on the ground isn't what I would call even engagement, if you don't know what the plan says.
One of the biggest statements you'll hear in our community is ending the epidemic for whom? Because folks don't, you hear that a lot because folks don't know who it was really designed for, and or by. And so I totally agree with you about ownership. People support what they help create. Some of us have been talking about this for a while and talking blue and recognizing too that was this launched in 2017, 2018, whatever, the State of the Union. But we got a whole year. I never understood why a plan had to be submitted. And I know CDC pushed back the deadline to December when we were in the middle of COVID. Nobody was meeting. I mean, it was already, tons of stuff going on. People, HIV were being moved to COVID. And so to even think that a process could proceed in that time was already difficult. But I totally agree with you. And we've been talking about, what does community ownership look like? Who is community? Who is the plan for? What is different about it? What will be different? And I would like, one of the things that I'm also a part of the PL HIV networks in the US, who have been wanting to, kind of bring this to the HIV community. We've tried to organize this with Antigone and all of them, and we just kept getting the signals crossed in terms of timing. And then it went into the election, which election was huge for our community. So you could not be doing that. It was already COVID, election, and then trying to do this. So we would love to work with you to bring some level of ownership and some engagement to the HIV community through the networks of people living with HIV that we have here in the US, and they have them globally as well. So I'll say that. Because we don't own it now, you're right. We don't own it, and we don't feel like it's for us. But we'd like to, because we have a vested interest in it.
That's right. Not only a vested interest, but it is a vested interest. It is the roadmap that is referred to, that is just as strong as the conversations about integrated plans that we don't follow on the local level. It really makes me question the ability and the commitment to end HIV, especially as we see the differences between reaching 90-90-90 in these communities. Whether we talk about New York or we talk about Houston, is these state and local commitments to racial justice and equity. And it is particularly an important conversation in the South, as we know there are multiple systems on multiple levels that are set up to disenfranchise, to marginalize and make Black communities invisible in the response to HIV, less than just being a consumer of HIV services. Not a leader in the work, not a funded partner in the work, but volunteers and individual voices who are paid minimal fees to disclose HIV status at will in order to bring in and procure more funding on local and state levels. So how do we change that? And hopefully this is, as we prepare our last 15 minutes of this conversation, that is a piece that's super important for all of us on the phone to really navigate, because again, we're in this kind of holding pattern, but then when it's out the gate, it's out the gate. Then we get into this, we need this tomorrow for the next set of deliverables and deadlines. And so where it feels like a quiet moment, quiet is relative to dealing with COVID, snowstorms and being killed in the streets, but
Yeah.
why we have a quiet moment, how can we work on some of these different issues that have already been brought forward, and prepare these conversations for those administrative leads as they take power and is seated in their positions. So Harold, I want to see if we're going to just take a moment to go into some closing thoughts. Harold, I want to go with you, then Matthew, then Benita, and then I can be able to close us out. But maybe you can just share some thoughts about our discussion today, and really how do we navigate a very challenging place as activists, as policy leaders who are trying to make an earnest attempt of coming to the federal, state, and local tables to be a part of these plans, and more than just a way of disclosure of HIV status, but to truly put the leadership that many Black communities have advocated for the last 40 years of this epidemic.
Well, let me start by saying I really appreciated today's conversation, even though it has given me a headache. And I think it's given me a headache because I think our first step is making sure that you all know what's in those plans,
Mm-hmm.
and that you ensure, like, I'm sorry, that level of transparency is basic when I think about community engagement.
Mm-hmm.
And so this concept of that part of it's not working. We need to rethink the pillars. But first and foremost, I gotta get you all to see the plans, to give us some
Mm-hmm.
feedback as to whether or not that plan reflects what you said the priorities were in your community. I can't
Right.
even get to, does the plan include the right kinds of partnerships to be able to address housing or employment issues and healthcare issues, because you all don't know what's in the plan.
Right.
And so what I need is you all to be able to sort of react to what's in there and then tell us where to go and what needs to be done. And this piece of ownership rather than engagement is on my list of things. As the administration said, we're going to need you to think boldly. Well, yeah, how about community owns these plans and we give them as directives to the health department? Make this happen. And whatever those sort of procurement systems are, purchase order, contracts, cooperative agreements, grants, make sure that they're all at the disposal so we can act like this is an epidemic.
Right.
There were incredible things that we saw happen as a result of COVID-19 that have never happened in the HIV world. And there are lots of different reasons for that. But we also know that the same communities were disproportionately impacted by both of those infectious diseases. So bringing to bear some of that ingenuity and creativity on the federal and state and local level about how we move money, how we get things out. How is it that you set up a vaccination center overnight?
Right.
So all of that, somebody moved some contracts, somebody moved some kind of purchase order agreement.
Right.
We need some of that commitment in HIV. So I'll just stop.
Harold, one thing I will just respond to you and say that there are a number of communities, including Dallas County, that submitted letters of non-concurrence that provided very solid recommendations on what needs to be done. So the thing is, I can't speak for some others in community, but we saw the Texas plan that included every EHE jurisdiction except Houston. And we provided a letter of non-concurrence. And so one question that I would ask that for those communities that were asked to provide a letter of non-concurrence, how are those being received and already put into consideration as action items that have been particularly provided from these communities? Because I'm clear and have already seen that the plan is not a good plan, and many plans, it's not that the plan didn't, like, people just not only did not see the plans, it's a non-concurrence because they weren't a part of the planning process. So that invalidates the planning process that was supposed to be, like co-driven by community. And when I say community, I'm talking about all of the stakeholders outside of the health department. So even as we talk about, the nuance or maybe not so nuanced voice of the person living with HIV that's still navigating their own status and disclosure to family, friends, and whoever, we have hard-hitting community leaders who, because of the conversations that you offer us, and in webinars like this and other federal partners who are getting out and meeting directly with communities, has given us the tools to equip ourselves to ask questions about this process. Why are we failing on the HIV response to deal with COVID when both COVID and HIV has been fully funded? Like, why are these things not lining up? And what is the bilateral piece of communication that's getting information not only to HRSA and HHS, but also to your technical assistance partners, to make sure that the conversation that we're having is not just federally driven, but we are taking in the vein of implementation science, an approach of understanding that we have a problem in front of us that needs to be addressed immediately. And it is causing a critical error in how the plan or the conceptualization around the implementation of the plan to be done. So that to me stops the process and says these plans are not going to work because there are so many people that are not being a part of this planning process. And if there are, some stellar plans that are being put forth, how do we start, or the technical assistance partners start putting those promising strategies in front of those health departments sooner than later, before the priority becomes getting the next RFP in versus fixing the problems that were not done with the current money that is being spent down on behalf of this plan to end HIV.
So did
go
you
ahead.
say, did you all send a letter of non-concurrence for the plan that was submitted in December?
Sure did. I can send it to you. Would you like it?
Please do, because I'm hurt that you
Absolutely.
didn't send a copy.
I didn't even know we
And
I
had.
thought you got it.
And
I
I
guess
think,
you will.
and you would assume CDC would have sent it to me, didn't you? No. So I think that's also, when we think about what's working and what's not working with EHE, I think we also need to sort of also look at this structure, because there's funding that goes to HRSA, there's funding that goes to CDC, and then my office and the assistant secretary, but HRSA and CDC all have their sort of grant and cooperative agreement and their TA mechanisms.
Right.
But a lot of my information not only comes from them, because I'm meeting with them frequently, and often they tell me what they want to tell me, like anybody does, but also some of my information comes from the community and has the ability to follow up on some of those issues. But I don't know that every community knows that, and you probably sent it to CDC and only CDC because it was sort of a grants issue with the planning piece, and didn't think about, we need to include the COO in this, the chief operating officer for ending the HIV epidemic, in the assistant secretary's office, so that he can follow up on these issues, because you all assume, in a spirit of transparency, that there's a conversation happening about, oh, by the way,
Right.
the community
But
is not
Harold,
pleased with this plan.
these plans did not go to CDC or the state health departments. It was, the letter went to the department that we were talking about. So we don't know who it got to after that, or what it was attached to in the official submission of this work. So again, we wrote the letter so that we can document the challenges that we had with the process, but we don't know what happened, to it. And that's where I think that there's a desperate need to create and open that pipeline of communication so that people can feel that their voices are being silenced as community leadership. What is the platform to open that conversation up if you are not in a place of privilege to have existing relationships with those key officials? How do we make this plan and the ability to provide engagement around this plan as simple as possible, as we are asking for the voices of marginalized communities who are dealing with national catastrophes, who are dealing with insurance copays being declined, who are dealing with all of these issues in a very primal, real-time sense. Bills not getting paid, food's not getting put in mouths, shelter is being compromised in a way. So it's hard to get people to want to be a part of this work when we're not finding ways to be expansive in this conversation of how we do that. And now we have exceeded the time that COVID can be blamed on this, because then we go to the next catastrophe. So that's where I think is a key conversation, a critical conversation, because it's still so disheartening now to be at the damn near March, and we are having a conversation with HHS about documents that haven't been received that was supposed to be a part of our official submission to the work. So again, this is something that I hope that we can continue to work with you, HHS and CDC and others to be able to navigate. So I know we're going to be going just a little bit over time. I do want to allow Vanita and Matthew to have closing thoughts.
Go ahead, Matthew. I think
mine are pretty straightforward. I think that there is a lot of opportunity with healthcare expansion. But as I said at the beginning, healthcare and insurance is only one side of the equation. There has to be bold and dynamic community engagement to get people to understand and educated on this. Figure out how you like to receive information as a group, and then how you give feedback, and then let people know what those things and standards are. There are, as you can see, it becomes a bit of a game of telephone from where Harold is in Washington and I are in Washington to getting it down to folks on the ground. And so we need to make sure that that telephone cord has both direct access to the people at the top, and also the message is also being at least being heard at the bottom. And if there's an issue with it getting pushed up, that we know so we can do something about it. But I think that there are a lot of opportunities, and this is truly a ship that can be built as we fly it, because that's literally what we've been doing for the last year. Like, nothing is set in stone, and even if it is, we got some big hammers and some mortar. So that's my thoughts.
And
Thank you, Matthew. Vanita, go ahead. Oh, go ahead.
yeah, just quickly, Vinton, I think you summed up what I would have said. You know, we don't even know what, we don't want to just know what's in the plan. We need it to be included in developing the plan. So that's one thing. I think one thing about really defining what engagement and ownership is, and giving, you know, real direction to our health departments and others about what to do and what that has to look like, not just using the term and everybody reinterprets it. I think more transparency about, you know, what it is, who's doing what, I think is also useful. And I guess I think I've said everything I wanted to say. The last thing though I would say is, while we're having this discussion, and this is almost March 2021, still Black folks are the ones most impacted. All of this still impacts us the most. And I just want to see the political will. I don't want to just see the words of root out systemic racism, or you know, Matthew said it too, just the use of the terms. I mean, we didn't just discover anti-Black racial violence with George Floyd. This has been going on for a long time. I want to see real action and commitment, because while we are talking about this, more Black folks are still being disproportionately impacted by this. And, you know, for myself, I may be a woman living with HIV, but I don't want to see another person diagnosed with HIV or another person die of HIV, because even though we talk about the treatment advances, which I'm really grateful for, in my community, I can tell you in our small community, we probably have lost maybe 15 people in the last 4 years amongst a small community because of complications and other kinds of things. So folks are still dying, folks are still becoming positive, folks are still not getting access to healthcare. And like right now, I told you, just got a letter from the state health department yesterday after having to daylight this issue and push back of delaying you know, the implementation of something again without transparency and no involvement. Email sent December 28th to, you know, providers saying, oh, by the way, this is going to happen. No notice to the people who it's going to impact. They won't know till they go to recertify or go to the pharmacy to get their medicine. That is not the way we can do that, because at the end of the day, again, it is Southerners, it is Black folks, it is Black women, it is Latinx folks, it's you know, who are most impacted. So I want to be a part of a process and a solution that addresses that. But I want to call out that we've got to do something real different in order to do that.
Thank you, Vanita. Thank you, Matthew. And also thank you, Harold, for being a part of this very important conversation, and just continuing to be a partner in this work, and really getting out and hearing the voices of community and the needs of community, and taking that into the federal government and turning that into action. So we just continue to appreciate your leadership in the federal government, and appreciate important voices like Vanita and Matthew to continue to advocate for the needs of key communities, particularly Black communities, in our ongoing fight and our commitment to finally get a hold of the HIV epidemic, as we have successfully navigated COVID in less than a year. With that, that's my humor for the day. But seriously though, thank you so much. And thank you to everyone who made time to be a part of this conversation. We will definitely continue moving this dialogue, as it is something that cannot be episodic. It must be something that is a continuous conversation and a continuous drumbeat for the justice and equity that we are seeking today. So with that, thank you everyone. Have a wonderful afternoon. And thank you for being a part of this conversation.
you.